We have 3 neurosurgeons, and we have an Algerian neurosurgeon, a Guinean neurosurgeon, and also 1 resident from Tbilisi University Hospital, which is located in Georgia. So we can start. For the attendee, good evening for you, and welcome to this webinar dedicated to the brain injury. So today we have a great information for you about some unusual rare cases of brain injury. So the first speaker, Professor Daoud Souad, is an Algerian neurosurgeon who will tell you about some unusual rare case of brain injury in the case of children. However, the second speaker, Eman, will show you some atypical neurosurgical cases which have passed in emergency of her hospital. And the third presentation will be presented by 2 students from Bavani College of Nursing, by 2 Indian students. The students will tell you about some cases or some presentation about the brain injury. And the last speaker, the Guinean neurosurgeon, will present to you the importance of the international training for the student, for the resident, in order to the management of the brain injury and also other neurosurgical pathology. So let's go with the first speaker, Professor Daoud Souad, who is the head of Department of Neurosurgery at University Hospital of Oran. Let's go. You are here, Professor Daoud? Elimam, who will present to you some exploring the Atypical in the traumatic neurosurgical emergency. Eman, you are here?
Yes, hello, I am here. Thank you.
Can you introduce yourself for the attendee?
Yes. Just a second. Hello, everyone. So, I'm Eman, and I am a final year medical in Tbilisi State Medical University, and hopefully I'll be sharing a topic that would be interesting to majority of students and residents, and hopefully someone would learn something from it. And it's going to be titled Beyond the Norm, Exploring Atypical in Traumatic Neurosurgical Emergencies. And the aim of this is not really to teach people how to handle neurosurgical emergencies, but to open the possibility that there are better prognoses and prognoses that we are not aware of in neurosurgeries. So I hope it would be interesting after Professor Daoud, definitely. Thank you so much.
Yeah, definitely. Welcome to Dr. Eman. Welcome to the event. Thank you so much for joining the event today and agreed to share the insights. And definitely, we are looking forward to some great knowledge from you. We are looking forward to it.
So for Eman, can you start and you replace Professor Daoud if it is possible?
Okay, sure. Someone said that Professor Daoud, yes, Dr. Daoud is here. So can you check again if they are? And then if not, I can start.
Okay.
In the chat box, it was written Dr. Daoud is here.
Yes, Dr. Eman, my teammate wrote that message. And that time Dr. Daoud was here, but I think she's not here in the meeting room. at the
Okay.
moment. Yeah.
All right. Yes, I can start. I hope it would be a light start and it wouldn't take a lot of time. And I do hope everyone gets to learn something from it, including myself, while preparing this presentation. And so to start off, my title is Beyond the Norm, Exploring the Atypical and Traumatic Neurosurgical Emergencies, and it's co-authored by my sister, Noon Elimam. And we know generally in the field of neurosurgical emergencies, we have great differences in presentations. We have very common cases to very rare cases that we see. And the presentation is meant to address the atypical cases or presentations and unexpected manifestations that we are going to see. And briefly, I will introduce just a little bit of the common standard cases that we often see, and then I will address some cases that are related to delayed symptom manifestations or silent symptoms, or even addressing neuroplasticity in neurosurgery and addressing cases with acquired savant syndrome after traumatic brain injuries. So I do hope it would be interesting. And if anyone has any questions, please do write them in the chat box and I will try to answer them afterwards within the best of my knowledge, okay? So we can start, I suppose. So briefly, to start with is what are traumatic brain injuries? And as we all have a background about them from hearing the name, what are they? And they are basically either mechanical injury or trauma that happens to us. And it can include falls or accidents or any injuries that are related or traffic road accidents or even assaults. And they can be mild, moderate, or severe. And a lot of times we use the Glasgow Coma Scale to assess how severe the cases are. And epidemiologically, we know that around the world, around 70 million or even 69 million cases around the world happen yearly. And that's almost 200,000 daily emergency visits because of traumatic brain injuries. So it's quite essential for us to understand the different mechanisms and understand the fact that manifestations are different from person to another. And also keep in mind the references at the end of the slide. And if there are any references that are not included, please feel free to reach out and I will share them. Next. So just brief cases that you may see regularly as either a neurosurgical resident, even a surgical resident, or someone who's an ER nurse or even a medical student. And these are cases that we see quite often, which are typical epidural hematoma. You have a patient who had a blunt injury and he has loss of consciousness and a lucid interval and then deteriorating consciousness throughout. And you will see it on the CT scan as a biconvex shaped collection of blood. And this is a typical epidural hematoma. And when we see something like this, automatically we think of a rather positive prognosis if it was treated early and the patient could make a full recovery after the operation or after operating on a craniotomy or a surgical procedure. But if it's a poor prognosis, if there is brain herniations or it's very delayed or untreated, and the mortality rate could be 5 to 10% in this case. So automatically we can take a guess on how the patient prognosis is going to be. Next, we have, for example, acute subdural hematomas, and you will see a patient fell from somewhere or hit his head in a blunt, strong blow, and they were drowsy and had the Glasgow Coma Scale of 13. And after hours, he gradually becomes unresponsive. And on the CT scan, you see a crescent-shaped hemorrhage between the brain and the dura. And this is consistent with acute subdural hematomas in patients. And again, when we see this, we have an assumption of the prognosis of the patient, whether it's going to be positive or negative. It's usually variable because in older patients or very severe injury or delayed treatment, delayed surgery, there is high risk of permanent neurological damage and a mortality rate of over 50% in elderly or comatose patients. So the key factors are prompt evacuation and managing as soon as possible. Next, we will see this quite often, especially in traumatic road accidents. And sometimes this doesn't happen directly as an impact of the accident. It sometimes happens because of the management after the trauma. So you will see someone having a car crash and people rushing to save them, and someone tilts the neck in an attempt of doing CPR or so on, and it causes damage or an injury to the spinal cord. And this patient is going to end up being quadriplegic, not because of the trauma, but because of the maneuver that someone did trying to save them. Even injuries can cause, blows can cause this. And when it comes to this, the prognosis typically we will say is survival rate. It could be good with early surgical stabilization, but when it comes to severe cord injury, it could result to permanent paralysis. And this is the interesting part of neuroplasticity that we will touch on later, that there are really rare cases that neuroplasticity could play a role and the patient could recover, which is not really common, but could happen. And this is what I be wanting to touch on a bit later. Next, typically, is penetrating trauma injuries. Patient could come with whatever Glasgow Coma scale, and it could be caused by a sharp object or even a blunt object, but it's penetrating. And the prognosis is usually poor, and the patient will have severe neurological defects and deficits as well. And mortality rate is up to 90%, depending on the localization of the injury. So next. So these are the typical presentations. I think everyone would be generally familiar with them and or have seen them before. But now we have the atypical presentations, or things that we don't regularly see in these cases. And when it comes to that, we have delayed symptoms. We have patients who have symptoms that manifest hours or even days later after the initial trauma, and they could manifest differently. They could be seizures, they could be confusion or headaches that last for days. We have silent injuries, small like concussions that you will not see on the CT scan, and the patient will not have any manifestations, can come later and show up, and the patient will have severe conditions later developing. And sometimes the unusual mechanisms of the injury, like shaken baby syndrome, it shows later on as neurological manifestations and not rather momentarily at the time, even though it's a trauma. So next, please. So when we're having delayed or silent injuries, we also consider delayed hemorrhages. Usually we know there is a range for example, acute hemorrhages. It will be, for example, 10 hours to 72 hours, and then it's subacute and then chronic. But sometimes what if this acute is prolonged? And this is not really common, but one of the cases I will be showing shows this manifestation. Post-concussion syndrome. Usually for concussions, we have conservative management of observing the patient and making sure they're stable. But sometimes post-concussion syndrome happens and the patient has gradual decrease as well, to gradual decrease of consciousness and gradual decrease of neurological function. And silent injuries, where there's no immediate symptoms, there's no CT manifestations, there's nothing, and the patient could present later with neurological defects. So we should be aware when we're assessing a patient, just because they don't fit the typical criteria of, oh, this is a neurological or neurosurgical emergency, that we just dismiss the patient's concern. So next. So, for example, this is one of the cases that I would want to touch on: development of delayed acute subdural hematoma after mild traumatic brain injury, a case report. And this was one of the case reports that caught my attention while I was looking into this topic. And you have a patient who fell a minor fall. It wasn't even that major, and it was a middle-aged man in the 50s, and he just came to the emergency department with an mild headache and Glasgow Coma scale of 15. And in CT, there's no intracranial lesions, nothing, and no fractures, and the patient is stable. And this patient, when he comes to the ER in many countries, he does not even fit the criteria of doing a CT because it's just a mild injury. He did not have any manifestations, and his Glasgow Coma scale was on 15. He scored 15. So 8 hours post-trauma, he was put on observation, and 8 hours post-trauma, he started developing seizures and disorientation. And then they made another CT. And in this CT, it revealed an acute subdural hematoma with a midline shift of less than 2 millimeters. And this is all completely normal, because we know that acute subdural hematomas can develop even after this time, 8 hours, 10 hours, and 15. So this is not the concern. Next. But so we see the initial CT scan completely fine. He just have subgaleal bleeding, and then the next scan we see the acute subdural, and this is again within the normal level or within the normal range of the time of acute subdural. But what is interesting is what's next in this case is next, please. In this case, so they initially monitored the patient symptomatically, stable condition. They said, okay, the bleeding is not increasing. There's no manifestations and the patient is normal, no hematoma volume changes, and the patient only has moderate headaches. So he was monitored for 1 to 5 days. And afterwards, on day 8, the patient had deterioration in motor function, and it deteriorated to grade 5 on the right side, and the mass of hematoma increased, and this was detected on CT. So they returned him back to the ER. They did the surgical intervention of craniotomy and hematoma evacuation, and postoperatively, first day, CT showed no mass effect and motor function was nearly recovered. And again, third day postoperatively, the patient had a recurrent acute subdural hematoma, and again, a repeat craniotomy and hematoma evacuation, and then was discharged on day 10. Next, please. So in this case, a lot of times it's not typical for a person to have a worsening of acute subdural hematoma on day 8. So in this case, in this patient's on day 5, I mean, in this patient's case, it happened a week after the initial blow where the deterioration happened. It was stable for a few days, and usually he will be dismissed and told to come back if there's any symptoms. But in this case, it didn't recover, it didn't resolve on its own, and he had to come back for surgical procedures twice. So we keep in mind that these cases could happen. It's not as common, and it's still an acute subdural hematoma, and we don't see that it turned into a subacute or chronic because the bleeding was active at that time and the midline shift increased during that time. So it was bleeding, continuous bleeding happening at that time. So this was one of the cases of the delayed or the silent traumas that we may face in the neurosurgical emergencies. Next. So these are the post-operative CT showing the recovered midline, and the CT reveals that in the third day, the subdural acute hematoma was also recurrent again on scan B, and on scan C, after the second procedure, the evacuation, it was normal again at discharge. So this patient, a patient like this, always has to be under observation, because if he wasn't back for the second and for the first and the second craniotomies, it would have been a deteriorated case and motor dysfunction as well. So that was typical, but it was delayed. It was delayed and silent injuries. But we also have the interesting ones, which related to neuroplasticity and recovery in patients. And generally, the concept of neuroplasticity is our brain has the ability to recognize itself and reform neural connections after injury. So if the part of the brain is injured, this theory basically says that our brain is going to rewire itself and create new connections to compensate on the injured part. And this could lead to unexpected recovery in some patients. And it could also show that the patient would have an initial poor prognosis, but later show significant recovery and improvement. And obviously, with excessive rehabilitation and intensive therapy, it could also increase the long-term outcomes for our patients. And we can see one of those cases that was interesting to me. Next, please. Was a case that's related to cervical injury. Next. Okay, yes. So this was one of the cases that were very interesting to me. So as we know, as I mentioned in the initial case, when we have someone with the C1, C2 injury and the patient becomes quadriplegic, typically the prognosis is that he's permanently injured. It's quadriplegia. There's not really a positive prognosis to that. But there was this case, and it's extensive neurological recovery after a complete spinal cord injury, and a case report and hypothesis of the role of cortical plasticity. And it's talking about a patient who was around 60 years old, 58 years old, and he had a motor vehicle accident and had vertebral fractures at the level of C3 to C6. in September of 1974. Initial assessment, the patient had complete spinal cord injury, no motor, no sensory function below the level of the injury, and he also had absent sacral sparing. And the immediate impact of this is that he lost all motor and sensory function, and he didn't have respiratory problems. He stayed in the ICU for 5 days, and the initial management was spinal stabilization, and they used the halo device to stabilize, and rehabilitation started for the patient to test both upper and lower muscle group, sensory and motor, and he didn't have motor and sensory function in his lower and upper limbs. Next. So in a patient like this, as we can see, there was controls, and there was even a study done to compare this patient case with controls. And as we can see from the levels of C3 to C5 to C6, there was complete injury to the spinal cord, and compared to the controls where you can see clearly a healthy spinal cord and not injured. And next, please. And in this patient, the recovery wasn't really over a day or two. It was over 17 years. And the patient started from being completely quadriplegic with no sensory function to being able to run. And this is not a typical case. This is not something we will go and tell to a quadriplegic patient that, oh, there is a possibility you will start running in 20 years. Definitely not. But it also gives us an insight about the fact that neuroplasticity exists, and that we can see that this could be a thing that could be discovered in the future. So he had his accident, and a few months later, there was a flicker of contractions in the left big toe, obviously with physiotherapy and rehabilitation. Then initial sensory recovery happened around a year and around less than a year later, and started trunk movement and balance training. He started having active movements on the left arm against gravity. He started standing with 50% assistance, and this is happening over years, not over a day or two, definitely. He started beginning to have control over bladder movements, incomplete. He started to walk 40 feet without assistance, ability to walk in the community, and first run in 1991. Over around 17 years, this recovery happened. So again, that was a case of atypical prognosis or atypical timeline of traumatic brain injury. Again, we don't see it as often. Perhaps we should shed the light more in research on that aspect. Next would be Savant syndrome. And before I even explain what neuroplasticity has to do with Savant syndrome, I'd like to explain what is Savant syndrome. And we often see it in patients on the autism spectrum, because they will usually have the contrast of cognitive impairment, but they will still have an extraordinary savant skill. And we often notice it. For example, a patient will be on the autism spectrum, but will be really fascinating in math, or can play instruments and music really greatly compared to anyone else. And this is a savant skill. So it's the contrast, it's the difference between the skills they have. So acquired savant syndrome is not like the one we see in autism spectrum patients, but acquired savant syndrome happens after a traumatic injury to someone, and they suddenly develop a skill that they didn't have. And again, this is not common, but it's atypical. And a patient could go through a traumatic brain injury and wake up with a skill of math or arts, or they can suddenly start singing or so on. And neuroplasticity plays a role in this, and not only neuroplasticity, but there are a few theories that say that our brain, the certain other parts in our brain become active to compensate on the parts that are inactive. And in this case, we have two interesting cases I would like to mention. Next, please. So in this case, we're going to briefly discuss Mr. Orlando's case. And in 1979, he had a case where he was struck by a baseball on the left side of his head, and he didn't go get any medical help, and he just had suffered from mild headaches. But he suddenly developed the ability to do complex calendrical calculations, and this isn't normal, someone who's smart in mathematics. No, you can give him any date or time, and he will tell you exactly what day that was and what the weather was in that day, and he will never forget it. And this is a skill a savant skill that he developed after a traumatic injury to his head, or a strong blow to his head. And this was a specific ability he developed. And again, this is not very common, but it's a savant skill that he got afterwards. Next. Another case that we could also discuss is the case of Mr. Alonso. And this case is interesting because he got a severe brain injury as a child due to a fall, and he ended up with a severe intellectual and developmental disability because of that. And his IQ was around 40, and his mental development was around a 6-year old. But after this injury, he developed an ability and an interest in sculpting. He was able to sculpt or create from clay every and any single creature you could imagine. And that was the only skill that he was extremely great at compared to his developmental or IQ level at that time. And again, this is a savant skill because it's not normal within the scope of what has happened to him, and it only happened after the traumatic injury that he had. So this is also another thing we should definitely focus on more, which are discovering why savant skills occur, and if we can technically induce them in some patients, obviously not through trauma, but through other approaches like DBS or so on. Next. Just to briefly touch on the mechanisms of why savant syndromes could happen. And I have a particular interest in them because I was investigating what exactly triggers them. And we know that in the left anterior temporal lobe, when people have increased functioning in that part of our brain, they have exceptional memory and linguistic abilities. And sometimes when we have parietal lobe functioning extra hard, basically, they have better mathematical and spatial reasoning skills. And how do we get these regions in our brain to activate better is what we need to study. And some studies suggested that there is a difference in the brain connectivity and the patterns that are essential to create these savant skills. And again, neuroplasticity comes into play because if there is an injury to one part, then another part activity could be heightened, and suggesting that this heightened activity enhances functional coordinations in these patients. So there's no specific mechanism to why this happens, but it's one of the traumatic cases that could happen, one of the atypical manifestations. So I think just to wrap it up and to keep it brief is a lot of times we have patients with poor prognosis, and we basically lose all the hope, and we cannot really tell the patients that your prognosis is bad. But we should also remember that even in worst case scenarios, there are still cases of patients who managed to develop skills that are extraordinary or to recover in an extraordinary way. And we should never completely lose hope as healthcare providers or future neurosurgeons or whatever career we choose to do. This is quite essential. And just to wrap it up, I think that's all. Is there next? Yes, just to summarize, again, the typical traumatic brain injuries we see are typical concussions, contusions, compression, intracranial hemorrhages, axonal injuries. How we manage them is by early detection and prompt management. But there's also atypical manifestations, like we've seen the delayed symptoms and silent injuries. And we have to be careful and monitor those patients. And there's also neuroplasticity that plays a role into our brain's ability to recognize itself and adapt. And then savant skills or savant syndromes that do exist in some patients or will exist in some patients. And I think it also sheds the light of we need better research and better studying into these things. Perhaps they could have better prognosis in our patients in the future. And I think that's all from my side. If there is any questions, please do ask, and I will address them within my scope of knowledge. And if you don't have any questions now, but you remember any later, please send them to me, a text on LinkedIn or any way you wish, and I will try to answer them as well within my scope of knowledge. So, okay, there's a question on the chat box. How do unusual mechanisms of trauma, such as those not typically seen in neurosurgical emergencies, challenge conventional treatment protocols? Are there specific adaptations you recommend in these cases? So, unfortunately, our curriculum or the way we study medicine, it's not really easy to manage those cases because there is no specific guideline, there's no protocol that tells you how do you manage those patients. A lot of times you really cannot do anything surgically. There's only monitoring and making sure that the patient is stable. So if you have a patient who suddenly had a bad injury and started to develop savant skills later on, you cannot really do anything about it except to ensure that there is enough support for this patient. If a patient is having a spinal injury, you ensure that the patient is getting sufficient physiotherapy and rehabilitation to give them all the possible chances of recovery. There is no specific protocols, unfortunately, how to handle these patients because they're not as common. And a lot of times people miss them because they don't expect to see them. So I would suggest everyone to keep a vigilant eye on all of your patients and trust your gut sense. If you think a patient could have a silent injury, they're not really acting like a typical patient, or you see any symptoms that you suspect, trust your gut sense and keep an eye on that patient and monitor them. The next one was for patients presenting with atypical neurosurgical emergencies, such as silent injuries or delayed symptoms. Do their long-term outcomes differ from those with more common presentations? What are some factors that influence these differences? Definitely. So patients with atypical, for example, for the patient we discussed with the acute subdural hematoma that manifested on a longer duration than expected. So if it was in a lot of regions or a lot of countries over the world, this patient would have been dismissed. And when the manifestations happened again, if this patient did not get the help needed and the support at that time and the surgical intervention as needed, this patient would have had a really bad prognosis because it didn't happen during their stay in the hospital during 1 or 2 hours or 1 or 2 days. It happened through a week or more. So the prognosis, I think, worsens because we don't spot them quickly enough to ensure that they recover and get the support they needed. That's why their long-term outcomes could differ than normal patients. And obviously with patients with spinal injury, sometimes the longer you give it, the better. So the patient who had the spinal injury had the recovery over 17 years. So it's not that you will expect that for everyone, but sometimes it's unexpected and patients are quite determined, and rehabilitation does help them. And again, factors that influence them is just rehabilitation and keeping an eye, proper monitoring, and supporting the patients with whatever they need. And that's all. Again, if there's any questions, please do share. If not, feel free to drop them a text to me and I will answer as I within my scope of knowledge. I think that's all. Thank you so much, everyone. And I hope this was insightful. And I hope the next lectures will also be more educative on how to manage these cases or how to handle more neurosurgical emergencies from more of an academic perspective as well, because this was more of an insight rather than academia. So yeah, thank you so much.
Thank you so much, Dr. Eman. And definitely, as you suggested with the title, the insights were indeed beyond the norms. Thank you so much for sharing the knowledge with us.
Thank you for having me here and for everyone's time and focus as well.
Please stay connected. We are having some more presentations ahead and we might be having some more questions from you. And yeah, everyone, let us move to the next speaker. As suggested by Dr. Hapji, we were going to ask the students first, but I guess Dr. Daoud joined the meeting room. Do we have
Yes,
Dr.
Ghazel, Professor Daoud is here now, and she wants to present her communication, if it is possible.
Yes, it is possible. We
Okay.
can, yeah, definitely. We can go with Dr. Daoud first.
And thank you very much for Eman for this interesting information.
Hello,
Hello. How are you?
I'm fine, and you?
You have this problem of connection?
Yes. Now you can
So,
hear me clearly.
yes, you can start.
Okay, I will share my Can you see my screen now?
No.
Not yet.
It might take a few seconds. So let us
Okay.
see. Yeah.
And now?
No.
No,
It takes
not yet.
some time. Now, okay. We
Okay.
see higher, yes.
All right.
Okay, you
So
can
shall
start.
we start?
Yes.
Okay, so hi everyone.
Hello.
Can we
Today
maximize
we'll
the
present
slide? I'm sorry for the interference.
what?
Sorry for the, yeah, I'm sorry for the interruptions, but can we maximize the slide, Dr. Professor
Okay,
Daoud,
I'll try to do it.
if
Just wait.
possible?
This is better now?
Yes.
Okay, so shall we start?
Yes.
Definitely. Thank you so
Hello
much.
again. You're welcome. Hello again, and today we will present to you some cases of unusual head injuries in children. Let's start with an introduction. So we must know that head injuries in children are very common and most often are little or moderately severe. The particularity of head trauma in child is due to the fact that the child's brain is still growing and it occurs on a developing brain. So obviously, pediatric brain reactions are different from those of adult brain. They don't have the same characteristics, epidemiology, pathophysiology. So the management of head trauma differs from that in adults. Okay? Their assessment and treatment require more caution. We have to know that children are not miniature adults. For epidemiological data, we have to know that it's a very common pathology in daily practice. Third of all pediatrics emergency admissions. Fortunately, they are benign in 19% of the cases, and we have a male predominance of 60% of the cases. Unfortunately, it's the first cause of death in children over than 1 year old, and the third cause of death in children less than 1 year old. It's most common causes of death if the management is not done in the first 24 hours. So we must intervene as soon as possible. Okay, for the objective, the aim of our presentation is to show the frequency of this pathology with its unusual etiologies of head trauma in children and pediatric head injuries occurring in housing structures which are not yet completed, and to raise the awareness to avoid the dramatic consequences of those injuries. Materials and methods. In our retrospective study that was done in our Department of Neurosurgery of the University Hospital Center in Oran, from January 21 to September 24, with 689 cases, and our inclusion criteria were we have included children with the age under 16 years old, less than 16 years old, with benign head injury, and as etiologies, we had unusual causes. We will see in the next in the next slide. So for the etiologies, we have receiving a heavy object on the head, dog bites, sharp objects, stone throw, fall from heights like slabs, staircases, balconies. We will see in the cases coming. So we will start with this case of a child aged of 8 years old who was walking next to an unprotected field of houses under construction, and he received a stone on his head. With the CT scans, we could see a very large dent in the vault of the skull, and the patient underwent surgery. As a first advice, do not let children play in areas where constructions are underway. Another case for a child of a 21 months old child who was attacked by a neighbor's dog, and the clinical examination revealed several scalp wounds. For the skull X-ray, it showed bone fractures. In the CT scan, we could see some bone indentations, and the child, of course, underwent surgery. Operatively, we have found several depressed bone fragments and dura mater lesions, unfortunately. Another case of an infant who was attacked by a domestic dog in this case. Clinically, he had 3 scalp wounds. The X-rays showed fracture of the skull vault, and the CT scan showed 3 bone sheets, frontal, parietal, and occipital. The child, of course, underwent surgery. In intraoperative, we found several bone splinters, dura mater wounds, and a venous sinus wound. Fortunately, in both cases, the dogs were vaccinated. Another case with a 5-year-old girl who suffered from head trauma. So the patient received a television on her head, not the new televisions, but the old televisions that were big, you know. So clinically, she was conscious. She had a facial scratch and epistaxis. The X-rays of the skull showed multiple linear fractures, and the CT scans showed pneumocephalic and skull vault fracture. And for this case, we preferred medical treatment and monitoring. Another case of an infant who suffered from a head injury following a fall down from staircase in a house which wasn't yet completed. The height estimated at 3 meters, and clinically, the child presented trouble of consciousness, and the emergency CT scan revealed skull fractures and severe cerebral edema. Let's talk about the diffuse cerebral edema. It's the nastiest lesion in the neurotrauma and requires intensive care unit management. Another case with an infant age of 12 months who had a traumatic brain injury following a fall down also, but from the stairs, more than 5 steps. Clinically, the patient was obnubulated and had 2 scalp wounds, palpebral ecchymosis. The CT scan revealed multiple skull vault fractures, coronal suture disjunction fracture, which we call diastatic fractures. What are the diastatic fractures? They occur when the fracture line transverses one or more sutures of the skull, causing a widening of the suture. While this type of fracture is usually seen in infants and young children, as the sutures are not yet fused, of course. Another case with an infant age of 6 months who fell from bed with a height of 60 centimeters. Clinically, he had vomiting, intense mucocutaneous pallor, And on the CT scan, we could see an extradural hematoma. Let's talk about the epidural hematoma. It's a collection of blood that forms between the skull, so the bone, and the dura mater. The cause is usually an artery that gets torn by a skull fracture. The symptoms include severe headache and loss of consciousness. So do not let a child alone. Keep an eye on them. Another case with a 4 years old child who had head trauma with a welding rod which was implanted in the skull. The point of entry was under the eye. The child was playing in his father's workplace. The father was a welder. So clinically, the patient was conscious without neurological disorders, but the CT scans showed the path of the rod with cerebral contusion. The patient was admitted to the operating room to remove rod and repair cranial lesions. Another case of a 6 years old child with head trauma with a pair of scissors implanted in her skull. This child was playing with her brother with the scissors. We can imagine the scene. The brother was a little bit distant, and he threw the scissors, and they went directly to the head of his sister. The CT scan showed enforcement fracture of the skull. The scissors were removed, obviously, an intraoperative with repair of the bone lesions. Another case of a child aged of 2 years old who suffered from head trauma 1 month ago following a fall from balcony. X-ray and clinical examination revealed a linear fracture of the cranial vault. The patient was discharged under medical treatment in the first time, consulted today for swelling at the level of the skull vault. And we have done another CT scan. We have found progressive fracture, and the patient, of course, underwent surgery. What is a growing skull fracture? It's also known as a craniocerebral erosion or leptomeningeal cyst, which is due to unusual development of a cystic mass filled with cerebrospinal fluid in a rare complication of head injury, usually associated with linear skull fractures of the parietal bone in children under 3 years old. It has been reported in older children in atypical regions of the skull, such as the base occipital and the base of the skull base, and in association with other types of skull fractures. It is characterized by a diastatic, and we have talked about diastatic, so a diastatic enlargement of the fracture. Another case of a baby seen in consultation for cranial vault enforcement. The baby had fallen from little sister's arms, landing on a corner of a table. The skull X-ray showed a parietal fossa depressed, and the cerebral CT scan showed skull vault fracture with bone ingrowth. The baby underwent surgery, of course, for his fracture. What is a ping pong fracture? The ping pong fractures are a type of depressed fracture in which there is no rupture of the inner or outer table of the skull. It's produced by an incomplete bone mineralization. Its appearance is frequent during neonatal and infant ages and is extremely rare outside of these age periods, obviously. So never leave a baby alone with a toddler. Another case of a baby seen in consultation too for asymmetrical microcrania and signs of intracranial hypertension involving towards trouble of consciousness without notion of a fall or accident. A cerebral CT scan revealed a chronic subdural hematoma. Questioning of parents revealed notion of a shaken baby. Let's talk about shaken baby. The shaken baby syndrome usually occurs when a parent or a caregiver severely shakes a baby or toddler due to the frustration or anger, often because the child won't stop crying, for example. Babies have weak neck muscles and can't support the weight of their heads. If a baby is forcefully shaken, their fragile brain moves back and forth inside the skull. This causes bruising, swelling, and bleeding. So don't shake babies. So, as a care protocol, we have pediatric emergency, clinical examination, suture of scalp pleasures. It depends on the cases. We have to do our x-rays and then we wait 6 hours, of course, monitoring, and we do cerebral CT scans. And based on the results of the cerebral CT scan, we will know if we need to do a surgery for this child or not. So it can be an emergency or can be deferred for a few hours or even a few days. It depends on the case, okay? So to conclude, we have to agree on an idea, which is those affections are frequent. And in addition to the usual etiologies, we have also unusual etiologies. So we have to fight against this type of head trauma by raising the awareness and safety measures and supervision of children. As we said, we have to keep an eye on the babies, on the children, and all this to avoid some dramatic consequences. Thank you.
Thank you very much, Professor Daoud, for this good presentation. And for the attendee, you can insert your question in the part of chat box. If you have a question for this second presentation, Professor Daoud will answer your question after a few moments.
It was a great presentation by Professor Daoud Souad, and great
Thank you
insights
so
about,
much.
yeah, these were
Thank
great
you.
insights about unusual head injuries in children. Thank you. Thank you, Dr. Daoud.
Thank you. It was a pleasure for me.
Yeah. So as per Dr. Hapchi's plan, we are moving forward to the third speaker.
The third speaker is from Bhavani College of Nursing. We have two students.
Okay. So can I please ask the two students from Bhavani College of Nursing, Miss Abhirami.
Hello.
And
Hello,
line.
Sabrina. How are you?
Hello, fine, Habachi. How are you?
Fine, very fine.
Yeah, fine. Good to hear from you.
Thank you very much for each event you send your student in order to collaborate with our webinar.
Yeah. Thank you. Shall I introduce the speaker, ma'am, with your permission?
Yes.
Yeah. So, good evening, everyone.
The brain injury. This is the title of your presentation.
the audio was cut in between. I guess again the internet connection problems. Hello, Dr. Sampurna.
Over to Mr. Ma'am, please take over the session. Thank you.
Okay, you were audible. All right, let us give a few more seconds, Dr. Sampurna, till she come back.
The names of the two students are Abirami and Sandia from Bhavani College of Nursing. Yes, Abirami, you are not audible.
That's fine, Miss Abirami. Please take your time. You can reconnect your speakers. You can try to disconnect and then reconnect your speakers.
If you have a problem, we back to the last speaker.
Yeah. So Dr. Hapchi, let us give a few moments to
Okay.
Miss Abirami and Esan there.
So we pass to the presentation of the Guinean neurosurgeon, in which he will show you his experience in Algerian structure in Algerian neurosurgery department. So Dr. Komara will show you the interesting international training here in Algeria. You are here, Dr. Komara?
Yes, yes. Good evening.
So,
Hello, I'm here.
hello.
Hello,
How are you?
hello. I'm fine, I'm fine.
Where are you now?
At home, I'm home.
For another training.
Yes, yes, yes. Thank you, Dr. Abshi.
Thank you very much. This is why you chose this theme of the interesting of the importance of international training for the Guinean neurosurgeon in your practices and in your expertise.
Yes.
This is the title of your presentation.
Yes.
Okay. So I try to share your PPT.
Okay.
Yes. This is.
All right, we welcome Dr. Komara to the event.
Yes, sir.
Okay.
Looking forward to the insights from Dr. Komara Sheikh Ahmed, everyone.
Okay.
Okay, thank you. Thank you, everybody.
You can start.
Yes, we can start.
Okay.
Thank you, everybody. Thank you, Dr. Habshi and the organization of this conference for inviting me to this conference. The title of my communication, it is about the impact of our training in Algeria. Is
Yes.
enhancing neurosurgical management, the impact of international training on Guinean neurosurgeon expertise and practice. Let's go. Slide.
Okay.
Okay. In the introduction, we can say the neurosurgical care in low and middle income country like Guinea face significant challenge, including limited access to specialized training, equipment, and resources. This limitation result in suboptimal outcome for patient requiring neurosurgical intervention. However, international training program for neurosurgeons offer opportunities to bridge this gap by enhancing the knowledge, skill, and practice of local professionals. International collaboration between institution and high-income country and Guinean neurosurgical team have proven vital in addressing critical need in neurosurgical education. These programs provide Guinean neurosurgeons with hands-on experience, exposure to advanced medical technologies, and knowledge of the latest global standard in neurosurgical care. This partnership has the potential to not only improve individual competency, but also transform local medical practice and healthcare systems. Slide. This study, the objective of this study is to explore how international training impacts the expertise of Guinean neurosurgeons and influences their approach to neurosurgical management. By understanding these effects, we can access the sustainability and long-term benefits of such program in improving neurosurgical care in resource-constrained settings. We are 4 Guinean neurosurgeons, including me. We received a scholarship under the direction of Professor Sami Majid, a part of Africa Hand Project. This fellowship is given by the World Federation of Neurological Society. It is a fellowship involved participation in specialized training program focused in modern surgical technique and advanced medical technology. The study access to the outcome of the training through qualitative and quantitative measures, including participant feedback, skill acquisition, and integration of the new practice into their professional routine. This is images of the letter offering by Professor Sami Majid, who offered the scholarship. This is it is from Ministry of Education to authorize us to study in Algeria. Neurosurgery Training Center in Algeria. Major teaching hospitals such as the Mustafa Pasha University Hospital in Algeria and Oran serve as neurosurgical training center. These hospitals are equipped with advanced surgical theater, making them important hubs for resident education and practice. In Alger, there are 4 departments of neurosurgery: Mustafa Pasha University Hospital, Zemirli, Babelwad, and Atidir University Hospital. Slide. This is image of us resident in the operating theater, and we are training for these neuro-oncology cases. In our training, we study many cases like neuroimaging. This imaging MRI for glioblastoma. We study neuroimaging, many cases like skull fracture. We're showing this CT scan, showing this depressing skull fracturing. The first images is showing the depressing skull fracturing, and the second, it is pair operating images of this skull, depressed skull fracture. This is our experience in other experience. We do many cervical trauma cases. This is a case of fracture of C-set cervical spine trauma. This is the first image. We showing a fracture, and the second, it is osteosynthesis of this fracture after operating room. This is a post-operating result. This is our experience in our, the second experience in functional neurosurgery. We study many cases of functional neurosurgery in the trigeminal neuralgia. The first image showing the trocar, and the second image is after the balloon technique for treatment of trigeminal neuralgia. This is the images of post-operating of balloon technique for trigeminal neuralgia. In our study, we study only, again, microneurosurgery technique in the operating room, how to do suture in the dura mater with the microscope. After 5 years or 6 years of training, we are graduating in neurosurgery of University of Algeria. After we return to University Hospital Donka in Donka in Guinea, we have a neurosurgery department, many departments, but we have a neurosurgery department there. In this department, the first neurosurgeon, he is Dr. Biavogi, Professor Biavogi. He is a PhD, full professor in neurosurgery. He is the first neurosurgeon who studied in Moscow, and he was the pioneer of neurosurgery in Guinea. What is the impact of neurosurgical training in Guinea? After training in Algeria, the international training provides Guinean the opportunity to develop advanced surgical skills that are difficult to acquire locally due to lack of exposure to complex neurosurgical cases or modern technology. Training in country with better resourced healthcare system allows the surgeon to master intricate procedure like craniotomy, tumor resection, and spinal surgery. Slide. Next.
You see? Attends,
Okay, no problem.
no problem.
The specialization for neurosurgeon often work across a wide range of cases, but international training helps them gain expertise in specialized areas such as pediatric neurosurgery, neuro-oncology, or vascular neurosurgery. This leads to better outcome for specific patient population. Slide.
Next one.
Yes,
see
yes,
it?
yes, yes. We can have a reduction in complication with improved skill and knowledge. Neurosurgeon trained aboard are better equipped to manage complex surgery with fewer complications. This directly improves patient survival rate and recovery time, especially for high risk of surgery. The exposure to international best practice and guideline help Guinean neurosurgeons make better clinical decisions regarding preoperative planning, surgical technique, and postoperative care, leading to more favorable outcome for patients. Next. This training can able to this training in neurosurgery, the opportunity many patients in Guinea had to seek neurosurgical care abroad, as the expertise and facilities for complex procedures were unavailable locally. The increase in well-trained neurosurgeons has allowed more patients to receive care within the country, reducing the need for expensive and logistically difficult medical travel. The cost reduction for family and the healthcare system by retaining a patient with the country family are spread the financial burden of seeking care abroad, while the local healthcare system benefits from keeping those resources internal, improving the economy and the healthcare delivery simultaneously. This is other case we operate in Guinea with our neurosurgeon. It is a trauma, spine trauma with osteosynthesis. Next slide. This is the operating room in neurosurgery department. We saw the endoscope and this equipment, the new equipment in the operating room. In conclusion, The impact of international neurosurgical training on Guinean neurosurgeon has been transformative for both individual surgeons and the healthcare system as a whole by equipping neurosurgeons with advanced skill, enhancing local healthcare infrastructure, and fostering a culture of continual learning. International training programs have improved patient outcome and raised the standard of neurosurgical care in Guinea. Thank you very much for listening to my presentation.
Thank you very much, Dr. Komara, for this good presentation. And in turn, I thank you also for your recognition for
Yes.
your interest in training in Algeria. And
Yes,
you
yes.
show the importance of international training in the field of neurosurgery for
Yes.
the residents.
Yes, yes, yes.
If you have a question for Dr. Kumara, you can write
Yes,
them
okay.
in the part of chat box.
Indeed, these were great insights from Dr. Kumara Sheikh Ahmed. So we did had a few questions. Here are the questions we collected.
With the fellowship, providing exposure to advanced medical technology available in Guinea. How do you plan to manage high-risk neurosurgical cases with this technology upon your return? This is for the advanced medical technologies. This is the first question. The second one is, given the success of fellowship, do you believe similar programs should be expanded across Africa? What measures should be taken to ensure that the training's impact is sustainable in resource-limited settings? Question from Professor Daoud, the head of Department of Neurosurgery of University Hospital of Oran. So, based on your finding, what preventive measure would you recommend to reduce the pediatric traumatic brain injury in area with high-risk environments such as unfinished dwelling?
Okay. Hello? Yeah.
So for you, for the first question, what is your answer?
It is for the first question. In Guinea, after our training in Algeria,
Yes.
many cases in Guinea is not available, like cervical trauma fixation. After our training in Algeria, we do many cases of cervical trauma. We do many cases of cervical trauma, and we do one cases of glioblastoma. It is our experience training in Algeria. Because since in Guinea, there are no neurosurgeon to do cervical trauma. But after our returning in Guinea, we do many cases of cervical trauma.
You were 4 or 5 residents, you
Yes,
and Laiba, Dr.
yes,
Laiba,
yes,
in Tbilisi hospital,
yes.
Aminata
Aminata and
her brother in Babylwat University
Babylon.
Hospital,
Yes,
and Ba in
and
ATD
ATD.
establishment.
Mm.
Yes.
Since in Guinea, many cases we don't do it in Guinea, like cervical trauma, They didn't do it in Guinea, but after we return in Guinea, we start do cervical trauma, many cases of cervical trauma.
Okay. And for Professor Daoud?
Question.
We read the question. Base it on your findings. What are the preventive measure would you recommend to reduce pediatric traumatic brain injury? Can you summarize your experience of training in your department of neurosurgery, especially for the pediatric brain injury? You hear me, Kamara?
Hello? To reduce pediatric traumatic brain injury in Guinea or
Okay. Is there other question for Dr. Kumara? We can pass to the last presentation of two students of Bhavani College of Nursing.
Do I have to answer the question?
I'm sorry, Miss Abhirami.
Yes.
I'm grateful for this amazing clearance, amazing chance, Aushiras. It is a joy of participating in this event. First of all, I would sorry for this inconvenience.
That's fine.
Okay. Shall I start, ma'am? Ms. Gazel,
Yeah.
ma'am?
Yeah, please go ahead.
Okay, thank you so much. First, introduction. Trauma is the third most common cause of death. Head injury associated with traumatic brain injury occurs with an incidence of 20 to 40 cases as per 1 lakh population per year. Brain function is temporarily or permanently impaired and structural damage may or may not be detectable with current technology. Next, ma'am. Head injury. Head injury is any trauma to the scalp, skull, or brain. A traumatic brain injury, also known as an intracranial injury, is an injury to the brain caused by an external force. Increased intracranial pressure and increased in pressure inside the skull that may be a consequence or contribute to brain damage is known as increased intracranial pressure. Is the pressure inside the skull caused by the volume of three vital components. There is tissue from the central nervous system, intracranial blood volume, and cerebrospinal fluid. Intracranial pressure typically ranges from 5 to 15 millimeters of mercury. Next, ma'am. Intracranial pressure. Can I repeat this, ma'am? Is the pressure exerted by the cranium on the brain tissue, cerebrospinal fluid, and the brain circulating blood volume, constantly fluctuating in response to activities such as exercise, coughing, straining, and arterial pulsation and respiratory cycle. Usually pressure is measured in millimeters of mercury. At rest is normally 7 to 15 millimeters of mercury for a supine adult, becomes negative, averaging minus 10 millimeter of mercury in the vertical position. In this, some causes of increased intracranial pressure is hydrocephalus, which is an abnormal buildup of cerebrospinal fluid. This is the fluid around your brain and spinal cord. Some cases, bleeding into the brain, swelling into the brain, aneurysm, blood pooling in some part of the brain or head injury, brain tumor, infections such as encephalitis and meningitis, high blood pressure, stroke. Is this some causes to increase the intracranial pressure? Next, ma'am. Now we are seeing about cerebral dynamics. First, cerebral blood flow is 750 ml per minute, which is equal to 15% of cardiac output. In this, first, we seeing about production of cerebrospinal fluid. The choroid plexus of the lateral, third, and fourth ventricles create cerebrospinal fluid, which is removed by absorption into the arachnoid villi, dural sinus, and jugular system. The production rate of CSF is 500 cc per day or around 20 cc per hour. Elevation of ICP can be graded as follows. It can be normal within a range of 0 to 15 millimeters of mercury. If it is mild, means 16 to 20 millimeters of mercury. It is in moderate, means 20 to 30 millimeters of mercury. If it is severe, means 31 to 40 millimeters of mercury. If it is very severe, means 45 millimeter of mercury is above.
Yes, dear.
Okay, ma'am, thank you. This diagram is known about circulation of CSF, which means cerebrospinal fluid through lateral ventricle, third and fourth ventricle. The CSF is production and it goes to subarachnoid space and arachnoid villi of venous sinuses. And this goes to venous blood and arterial blood. Next slide, ma'am. Okay, next we have to seeing about pathophysiology. In this, first mechanism is in case of cranial insult, which means hello. Hello. In this cranial insult, ma'am, I'm audible, ma'am.
Yes, dear. You're audible.
Okay, ma'am. Okay, ma'am. Cranial insult, which means bleeding into the brain or swelling into the brain, which is leads to tissue edema in the brain, which is leads to elevated increased intracranial pressure. The elevated intracranial pressure is leads to compression of blood vessels. That leads to decreased cerebral blood flow. Next slide, ma'am. Next, the mechanism of elevated ICP2 is, first of all, decreased oxygen with death of brain cells, which leads to further increase in edema around necrotic tissue, further elevation in ICP with compression of brain, which is leads to stem and respiratory center in the brain was affected, which is leads to accumulation of carbon dioxide, which leads to vasodilation. Vasodilation leads to increased intracranial pressure resulting from the increased blood flow. Next, ma'am. Okay, next we have to see about clinical manifestations. First, we have to see physical symptoms. First one is unconsciousness. Due to increased intracranial pressure, the main symptom we noticed unconsciousness, which is what is that? Which is detected by Glasgow Coma scale. Next, severe headache. Next, repeated nausea and vomiting. In this case, vomiting is projecting, which means projected vomiting. Next one, dizziness, seizures, weakness, numbness in arms and legs, and dilated pupils of the eye. Next slide, ma'am. Next one, psychological symptoms. In this, slurred speech, confusion, agitation, memory or concentration problems, and amnesia about event to prior to injury. Next, ma'am. Cognitive effects. Difficult with attention and concentration, making decisions, processing information, problems with feeling motivated, problems with language, problem with reasoning, problems with insight, which means self-awareness, mental capacity issues also there in this case. Next, ma'am. Next one, perceptual symptoms. In this, we have to see paralysis of facial muscle, double vision, altered sense of smell or taste, swallowing problems, dizziness, ringing in the air, and hearing loss. Next one, ma'am. The last one is motor function. In this, decreased in motor function, control lateral hemispheres or hemiplegia, decortication, interruption of voluntary motor cortex, and decerebration. Decortication, which means abnormal flexion. Decerebration, which means abnormal extension. Abnormal extension is in this picture. It is a state of severe hyperextension and spasticity in which an individual's head, neck, and spinal column enter into the complete bridging or arching position, which is known as extension, hyperextension, ma'am. Next slide, ma'am. Hereafter, our people, Ms. Sandhya, carry on the discussion on the subject, ma'am. Thank you so much, ma'am.
Next one, diagnostic studies, history collection and physical examination, computed tomography, magnetic resonance imaging, electroencephalogram, posting emission tomography, measurements of intracranial pressure, lumbar puncture. Next slide, Ghazal. Measurements of intracranial pressure. Fluid-based system, ventricular catheter, implantable ICP sensors, parenchymal, the reading are based on zero drift of the sensor following pre-insertion zeroing against atmospheric pressure. Possible implementation include placement depend reading drift in zero reference values, bleeds and infection, subdural, applied in conjunction with the craniotomy, epidural as low sensitivity. Next slide. Measurements of intracranial pressure. Fiber optic, strain gauge, rheumatic, pneumatic. Next slide. Intervention for the patient with increase of therapy. Maintain cerebral perfusion pressure, prevent focal or global cerebral edema and focal brain compression. Nursing management includes maintains the patient's head midline to facilitate the blood flow, maintain the head of bed at 30 to 45 degrees to facilitate the venous drainage, avoid activities that can increase intracranial pressure such as suctioning and gagging. Treat hypothermia as it increases the metabolic needs of the brain. Decrease the environmental stimuli which can increase the intracranial pressure. Dim all lights, speak softly. Next slide, please. Intervention for the patients with the increased intracranial pressure. Touch gently and when needed. Space all interventions. Limit noxious stimuli such as suctioning to only needed. Maintain fluid balance via accurate by input and output. Overhydration leads to cerebral edema. Monitoring electrolytes balance as these patients are prone to hyponatremia, hypokalemia, hypoglycemia with diuretic usage. Monitor hyperventilation to maintain carbon dioxide level 25 to 35 millimeters of mercury to prevent vasodilatation. Next slide. Specific treatments. Surgical removal of intracranial masses, placements of extraventricular drain, placements of ventriculoperitoneal shunt. Next slide. Fluid restriction. Restrictive fluid to 65 to 75% of normal maintenance fluids used by 0.9% nitrogen sulfide is possible. Dextrose 5% of water may increase osmolarity of the blood and increase cerebral edema, may cross blood-brain barrier and negate effect. Hypothermia. Elevation of the bed. Raise the head of the bed 25 to 30 degrees to promote intracranial drainage. Promotes venous drainage. Avoid compression of jugular veins or kinging of the neck. Next slide. Pharmacologic methods. First one is osmotic diuretics. Mannitol. Dosage of 50 to 200 gram molecular Morse, 1 gram molecular by kilogram IV over 24 hours. Titrated to maintain urine output at 30 to 50 cc/HR. Glycerol. Dosage of 0.5 to 1.0 gram molecular by kilogram every 4 to 6 hours. Do not exceed 0.2 to 1.0 gram by kilogram by hours. Loop diuretic furosemide ethacrylic acid. Dosage of 0.5 to 1.0 mg by kilogram. Corticosteroids. Dosage of dexamethasone most commonly used 10 mg IV and IM followed by 4 mg IV by IM every 6 hours. Next slide. Research updates. First one is monitoring technologies, therapeutic interventions, predictive models, ICP and neurodegenerative disease, TBI. First one is monitoring technologies. Monitoring technologies advanced in non-invasive monitoring techniques such as transcranial Doppler ultrasonography and optical forensic tomography, or making it easy to assess the intracranial pressure without the needs for invasive procedure. Second one is therapeutic interventions. New treatment approaches or behind explored for managing elevated by ICP. This includes novel pharmacological agents that can reduce cerebrospinal fluid protections of improve our cerebrovascular regulation. Then third one is predictive models. Researchers are developing computation models to predict intracranial pressure changes based on various factors, including patient demographic and underlying conditions. These models aim to improve individualized treatment plans and outcomes. Then ICP and neurodegenerative disease. Studies are increasingly focusing on the role of intracranial pressure, neurodegenerative disease. Research is exploring how the abnormal intracranial pressure may contribute to conditions like Alzheimer's disease and multiple sclerosis, potentially offering new avenues of treatment. Then last one is TBI. TBI means traumatic brain injury. This traumatic brain injury in ongoing research into optimizing intracranial pressure, managing in TBI patients, including exploring the timing and types of interventions that can minimize secondary brain injury. Next slide. Conclusion. The central nervous system may suffer irreversible harm from a rise in intracranial pressure, commonly known as intracranial hypertension. If the intracranial pressure is less than 10 mmHg, it is deemed normal. Neuronal damage can occur when the intracranial pressure rises above 20 mmHg. All through the cerebrospinal fluids, pathophysiologic response helps to reduce the rise in intracranial pressure. It frequently falls short of what is needed to prevent harm to the central nervous system. The doctor can reduce harm from intracranial hypertension by using the therapeutic methods discussed above, provided they have a true understanding of the physiologic components of the cerebrospinal fluid. Intracranial pressure monitoring offers unbiased information recording the effectiveness or ineffectiveness of therapeutic interventions. Next. Thank you. Grateful and truly blessed.
Thank you very much for this educative presentation. It's a reminder of some neurosurgical courses. So if you have some questions, you can write them in the part of a discussion, chat books.
We did collected 1 or 2 questions. Let me ask if we are having Dr. Sampurnam here. or if Miss Abhirami would like to answer the questions, please. I would request my teammate to please send the question in the chat box. There are two questions. So if I'm audible to Miss Abhirami and Dr. Sampurnam Webster, would you like to take the questions, please? All right, let's give them a few minutes. Until then, let me take a moment to give what all we got to know today, a crux to the event. So very first, we got to know about beyond the norms, exploring the atypical in traumatic neurosurgical emergencies from Dr. Eman, Omer, Elimam. Or else, I would like to get this favor from Dr. Habji. Okay, Dr. Sampurnam Webster has mentioned that Ms. Abhirami will answer the questions. So am I audible to Ms. Abhirami, please? Would you like to take the questions? Am I audible?
Yes, you're audible.
Yeah, you can unmute yourself. Yeah. Do you want me to read out the questions for you? I'd like to repeat.
So for the second question, for the difference in the brain injury outcome between the children and the adult, here we have some factor as the difference in the brain plasticity in children vs the adult. So we have, as you know, a difference in the brain development and the plasticity between the adult and the children. One of the most significant difference in the brain plasticity, as you know, the children have more neuroplasticity than the adult, meaning their brain are better in reorganization and forming a new connection. This ability can be a double-edged sword. While the children may recover certain function faster than adults, an injury during the critical period of the brain development can disrupt cognitive, behavioral, and motor skills in the longer term. In contrast, if for the adults, here, the adults have less plasticity, meaning that the recovery can be slower and less complete. But these adult brain are fully developed, so an injury doesn't interfere with ongoing development processes. This means that although the brain's ability to recover is more limited, the injury effects may be more predictable and less likely to cause future in the development of the brain problems.
Great information from Dr. Habji Nabil. Thank you so much.
Thank you.
Yeah, I would like to request you to give a crux of today's event, as I'm sure you will do it better. Before we leave from the meeting. So it will include what all we got to know today with our respective speakers.
Despite we have the problem of connection, we can pass all the speakers, the distinguished speakers.
That's fine, Ms. Hapchi. We will get the answers, and if anybody would like to have the answers, or we will paste the answers on our social media platform. So everyone get to know about the questions and the answers. Yeah. So let's conclude the event.
Yes.
Yeah.
You can conclude, Gaza.
All right. So thank you so much. So everyone, we got to know about Beyond the Norm, exploring the atypical and traumatic neurosurgical emergencies from Ms. Eman Omer Elimam as our very first speaker. Then we got to know about unusual head injuries in children from Professor Daoud Souad as our second speaker. And our third speaker, Dr. Kumara Sheikh Ahmed, got all the insights about enhancing neurosurgical management as the impact of international training on Guinean neurosurgeons' expertise and practices. And at last, as our third speakers, Ms. Abhirami M. and Ms. A. Sandhya from Bhavani College of Nursing gave the insights about brain injury. So this was it. We will soon announce our next event on our social media platforms as well as on our website. As I'm concluding the event, I would like to request all the attendees here, as well as on the LinkedIn live stream, to kindly share your full name, your email address, and your country name in the chat box or in the comment sections, respectively. Following information will be used for the certificate preparations. A great thanks to Dr. Hapchi Navel.
Thank you very much, dear Gazel, and thank you very much for the distinguished speakers for the interesting information about brain injury. And I would like also to thank the attendee for their interesting questions.
And with that, I would like to thank you for bringing great speakers to us. Thank you, Dr. Eman, Dr. Komara, Professor Daoud. And thank you so much for the support and always coming up with new topics and introducing your students and as well as your teachers from your institutions to Dr. Sampurna Webster. Thanks a lot. Thank you, Ms. Abhirami and Ms. A. Sandhya. We will let this event on for a few more minutes, as I know you all must be providing the asked information. So this is it. We are done with our today's event. Let us meet next time in our next in our next event. Take care and see you in our next event, which will be announced soon. Before leaving, I would like to thank Dr. Hapchi Navel and Dr. Sampurna Webster again, and to all the attendees and speakers who joined us and provided their precious time. Your suggestions and feedbacks are always welcome. This was Ghazal Johar, and the event was hosted by Dr. Hapchi Navel. And let us meet in our next event. Namaste from India. Take care and bye-bye.